Usually when we look at a medical procedure, there's this comforting expectation of precision. Like, you break an arm, the x-ray shows that jagged white line, and the doctor just points and says, yep, there it is, broken.
Right, it's very clear cut.
Exactly. We like things to be visible, to be perfectly categorized, but step into the world of cosmetic injectables, and that diagnostic certainty just completely vanishes. We find ourselves looking at a landscape that is incredibly murky.
Oh, it's the absolute definition of diagnostic muddy waters.
Yeah.
I mean, you go from a binary, broken or not broken situation to navigating symptoms that overlap. They mimic each other, and sometimes they just hide completely for months.
Which is terrifying. And that brings us to the mission for you today. Welcome to this deep dive. Today, we are looking at something wildly popular, which is cosmetic fillers.
Yeah, millions of people get them.
Right. Millions of people use them to smooth lines or add volume. And today, we're specifically zeroing in on highly mobile, sensitive areas. We're talking about augmenting the lips, the labial mucosa, and a procedure that is gaining massive traction right now called labial puffing.
Which is the cosmetic enhancement of the vaginal labia.
Right. And these are marketed almost everywhere as quick fixes. A lunchtime appointment and you're just out the door.
Oh, the appeal is obvious, right? But the sheer volume of these procedures is just skyrocketing globally. And that means the absolute number of complications is rising right alongside it.
Yep.
I mean, dermal fillers, especially hyaluronic acid or HA fillers, they are generally safe. Adverse events are relatively rare, but they do happen. And when they do, they are incredibly complex.
Which is exactly what we're going to get into. We are going to explore the hidden microscopic world of your skin and mucous membranes. It's this place where your immune system, resident bacteria, and these cosmetic gels interact in ways that completely challenge modern dermatology.
Fascinating stuff.
It really is. So we have a massive stack of medical literature and dermatology case studies to unpack today, and we are answering one highly specific question for you. Can labial fillers cause lumps, nodules, or biofilms?
To start making sense of these mysterious lumps, the clinical data insists we categorize them by when they actually show up.
Right, the timeline.
Exactly. Because timing is the ultimate clue here.
I noticed the literature draws a pretty hard line at the 4-week mark, so anything appearing within the first few days or weeks is considered an early onset lump. And surprisingly, these are almost entirely non-inflammatory.
Yeah, they aren't hot, they aren't red.
And they aren't infected, right. It seems to be purely a mechanical issue. Like the practitioner either injected the gel too close to the surface or maybe placed just way too much volume in one single spot.
Yes. And the specific anatomy of the lips and the labia makes that mechanical error even more pronounced.
Yeah.
Because both of these are what we call hypermobile areas.
And they move a lot.
Constantly. The muscles underneath are in a constant state of motion. You're talking chewing, walking, shifting. And that continuous kinetic energy actually acts on the filler.
Okay, let's unpack this with a visual for a second. It's like putting a dollop of really thick jelly inside a Ziploc bag, and then you constantly squeeze and roll and fold that bag.
It's a perfect analogy.
Right. The jelly isn't going to stay in a nice, smooth, flat layer. The hypermobile muscles basically massage the filler into a dense ball, which creates this unnatural firmness.
Right, it's just mechanical clumping. And with labial puffing specifically, if the initial distribution of the filler isn't, perfectly symmetrical, or if it migrates due to that continuous muscular pressure.
You get lumps.
Exactly. The patient can be left with quite asymmetrical, lumpy results, which is annoying, and it certainly defeats the cosmetic purpose. But from a medical standpoint, a mechanical clump is not a complex threat. It's really just misplaced gel.
Okay, so if those early bumps are just harmless mechanical squishing, that completely fails to explain the horror stories in these case studies. I mean, we are seeing cases of people waking up with fiery, swollen, red lumps 6 months or even a year after their appointment.
Yeah, it's wild.
And the gel hasn't moved for a year, so what on earth changes?
Well, this is where we cross into the territory of delayed onset nodules or DONs. And to understand what changes, we have to look at microscopic bacterial fortresses. They're known as biofilms.
The secret slime cities?
Yes, the slime cities.
I was reading the clinical data on these, and it completely reframed how I look at bacteria. Like, we tend to think of them as these solitary, vulnerable cells just floating around in the bloodstream,
Planktonic bacteria.
Right. But when they find a suitable surface, especially a foreign implant like a dermal filler, their behavior radically changes. They attach to the filler and start secreting this protective, slimy layer. The literature calls it an extracellular polymeric substance, or EPS.
and that EPS acts as a fortified wall. Once they're inside that slime layer, the bacteria are largely shielded from the host's immune system.
Wow.
Yeah. White blood cells physically cannot penetrate the matrix easily. And standard antibiotics, they often just bounce right off the surface. Or they can't reach the dormant bacteria hiding deep in the center of the colony.
That is so creepy. And adding to that defense, the bacteria inside the biofilm actually communicate with each other, right? Through chemical signals.
Yeah, it's a process called quorum sensing.
Quorum sensing, right. So they can coordinate their metabolic rates and bolster their defenses as a unified entity. They are highly organized. But, I mean, the obvious question for anyone listening who just got filler is, if the syringe comes out of a sterile package, where is this organized bacterial army coming from in the first place?
From the patient's own body, actually.
Oh, wow. Okay.
Yeah. The skin and mucous membranes are teeming with resident flora. Things like Staphylococcus, Streptococcus, and Enterococci, and they're completely harmless when they're just sitting on the surface.
Right, because they're on the outside.
Exactly. However, if the area isn't flawlessly disinfected prior to the injection, the needle acts as a transport vehicle. It literally drags surface bacteria deep into the tissue, depositing them right alongside the filler.
And this is where labial procedures carry a massive, very specific risk, because the sources point out that injecting through a mucous membrane, a transmucosal injection, is inherently dangerous. And that's standard for lip augmentation, and it's super common in labial puffing.
Right, because mucous membranes are notoriously difficult to fully sterilize compared to the regular epidermis.
Right, so you run a very high risk of dragging bacteria like Streptococcus aeruginosus straight into the filler bed.
And here's where the specific chemistry of the filler becomes an active participant. Hyaluronic acid, or HA, is a natural component of the body's extracellular matrix. It acts kind of like the biological mortar between our cells.
Okay.
So when these dragged-in bacteria encounter a massive synthetic dollop of HA filler, they don't just sit next to it. In vitro studies demonstrate that the presence of HA actively promotes biofilm formation.
Wait, really? So they are essentially using the filler as building materials?
Exactly.
It's like dropping a pile of premium bricks right next to a bacterial construction crew. And the mathematical advantage this gives them is staggering. Normally, for bacteria to overwhelm the immune system and cause a visible clinical infection, you need a high bacterial load. The number I saw was roughly 100,000 organisms per gram of tissue.
Right, because the immune system can easily handle a few stragglers.
But when a foreign implant like an HA filler is present, serving as a scaffold for that biofilm, that threshold just plummets. The number of organisms required to cause an infection drops from 100,000 down to just 100.
Just 100. Because the bacteria have that EPS shield to hide behind, they don't need a massive army to establish a foothold. They just need enough to seed the initial colony.
That is insane.
And once they do, they can sit there completely dormant for months. They metabolize at a crawl, doing just enough to survive, but not enough to trigger your immune system's alarm bells.
Which brings us perfectly back to the delayed timeline. If I get my lips or labia done, a tiny number of bacteria are pushed in and they build their little slime city. I don't see anything for 6 months. So what triggers the sudden explosion? Why does it turn into an angry red lump half a year later?
A systemic shift in the patient's body. Often, the trigger is an event of transient bacteremia.
Which is a temporary spike of bacteria circulating in the bloodstream.
Exactly. So, for example, if a patient goes to the dentist for deep cleaning or has oral surgery, bacteria from the mouth enter the vascular system.
Wait, a routine dental cleaning can trigger a massive infection in a lip filler from 6 months ago.
Yes. The bacteria travel through the bloodstream, they stumble upon that dormant biofilm sitting on the HA filler, and suddenly the dormant city receives reinforcement.
Oh my God.
The biofilm shifts from dormant to active, and boom, a localized pyogenic infection. You wake up with a fiery, swollen, delayed onset nodule.
That is unbelievable.
It gets worse. Viral illnesses or even certain vaccinations can also serve as triggers. They temporarily shift the immune system's focus, which allows the biofilm a window of opportunity to rapidly expand. It perfectly illustrates how deeply interconnected our localized cosmetic choices are with our systemic biological health.
I mean, that is a huge takeaway. But as fascinating as slime cities are, the literature throws a massive wrench into this whole diagnostic puzzle. Doctors will routinely biopsy these delayed, inflamed nodules, send them to the lab, and the culture comes back completely negative.
Sterile.
Sterile, no bacteria whatsoever. So if it's not a bacterial fortress causing the lump, it has to be the body itself.
Right. Now we enter the realm of the foreign body granuloma, This is basically the immune system's ultimate backup plan when it encounters a substance it just cannot destroy or remove.
Yeah, I was looking at the cellular mechanism here, and it is intense. So when filler is injected, the immune system dispatches macrophages, and their job is to swallow cellular debris or foreign substances whole.
Like biological Pac-Man.
Exactly. But a massive cohesive gel implant isn't microscopic debris. I picture it like a single cleanup crew member trying to swallow a king-sized mattress whole. They simply cannot phagocytose it.
No, they can't. And when the individual macrophages fail, they send out chemical distress signals. More macrophages flood the area, and they quickly realize they can't consume the thread either. So they change tactics.
What do they do?
They physically fuse their cell membranes together to form massive structures. We call them multinucleated giant cells.
So they form a biological blockade.
Precisely. Along with fibroblasts, which produce collagen, these giant cells construct a dense fibrous capsule, completely surrounding the filler. They isolate the foreign material from the rest of the body, and that encapsulated fibrous lump is the granuloma.
Okay, but the timing mystery applies here just as much as it did with biofilms. Why does the immune system suddenly decide to mount this massive capsule-building siege a year after the filler was injected? I mean, it ignored the HA gel for 11 months, so what flipped the switch?
It comes down to the enzymatic breakdown of the filler. Hyaluronic acid isn't a permanent fixture, right? Your body naturally produces an enzyme called hyaluronidase, which slowly chips away at the gel over time.
Right.
As the large cohesive HA gel degrades, it breaks into tiny pieces known as low molecular weight, or LMW, fragments.
So the immune system must perceive the intact gel very differently than it perceives those broken down fragments.
It absolutely does. The intact high molecular weight gel is highly biocompatible. It slips completely under the immune system's radar. But those low molecular weight fragments shed during degradation are highly biologically active.
Meaning they trigger a response.
Yes, they act as potent pro-inflammatory signals. The immune system detects these loose fragments, interprets them as a sign of tissue damage or infection, and launches a delayed attack.
And the specific manufacturing process of the filler plays a huge role in this immune trigger too, because some modern fillers use cross-linking technologies like Vicross to mix high and low molecular weight HA, creating a smoother, longer-lasting gel. But to bind it all together, they use specific sugar chains called oligosaccharides.
And those oligosaccharides are a major suspect in these delayed immune reactions.
That's the area.
To a circulating macrophage, certain oligosaccharide structures look suspiciously similar to the sugar structures found on the cell walls of pathogenic bacteria.
Wow. So it's a case of biological mistaken identity.
Exactly. As the filler breaks down and exposes these sugars, the immune system thinks it's looking at a pathogen and sounds the alarm.
So if a temporary HA filler causes this much trouble as it breaks down, what happens when someone...
The risk profile escalates dramatically there. With a temporary HA filler, if a granuloma forms, the filler itself eventually degrades completely. The immune system clears it away, and the granuloma often resolves. But with a permanent filler, the stimulus never leaves.
It's an endless siege.
Exactly. The body never stops trying to break it down.
And reading through the case studies on permanent hydrogels, the physical properties of the implant actually change over time. Like, as they sit in the body for years, some of these polymers begin to dehydrate, and the loss of water alters their chemical structure and their surface texture.
Which suddenly attracts a rush of inflammatory cells years or even decades after the initial injection.
It's a ticking time bomb.
It really is. That continuous low-grade immune battle can lead to severe, late-onset granulomas that are highly disfiguring. It is precisely why many of these permanent fillers have been completely outlawed in several European countries.
The long-term physiological cost was just simply too high.
Far too high.
So let's put ourselves in the shoes of the listener for a second, or a patient sitting in a clinic. You have a sudden, red, swollen, tender lump on your lip or labia 6 months after getting filler. How does a doctor even know what they are looking at? Because from the outside, a red lump is just a red lump. Biofilms and granulomas look incredibly similar, but treating them requires completely different approaches.
Well, misdiagnosing a delayed onset nodule isn't just an inconvenience. It can be medically disastrous.
Let's walk through that. What happens?
Let's imagine a practitioner examines an inflamed nodule and just assumes it's purely an immune response, a hypersensitivity reaction, or a granuloma. The standard medical protocol to calm an overactive immune system is to inject corticosteroids.
Right, because steroids suppress local inflammation by shutting down the immune response.
But if that nodule wasn't a sterile immune reaction and was actually harboring a hidden bacterial biofilm, Injecting steroids is like taking the guards off a maximum security prison. You have just deliberately suppressed the person's natural cellular defenses. Without the immune system keeping it in check, the bacterial colony can multiply unchecked.
So a small, firm nodule can rapidly evolve into a massive, aggressive, fluctuant abscess that just actively destroys the surrounding healthy tissue.
In a matter of days.
For you listening, this totally highlights why the credentials of your provider matter so much. If you develop a lump months after a procedure, you don't need a quick touch-up or a massage. You need a medical detective who intimately understands the pathophysiology of the skin and knows how to navigate the treatment hierarchy.
And the treatment hierarchy for hyaluronic acid fillers is very rigorous. The first line of defense is a drug called hyaluronidase.
The ultimate eraser. It's an enzyme that dissolves the HA filler. And bringing this back to our slime cities, the HA is the physical scaffolding the bacteria are clinging to, right?
Exactly.
By injecting hyaluronidase, the doctor isn't just dissolving the cosmetic filler, they are completely destroying the biofilms home. You pull the structural rug out from under the bacteria, stripping away their defense and exposing them to the immune system.
But dissolving the scaffold isn't always enough if there's an active infection. If the nodule is warm, tender, or, appeared shortly after a dental cleaning, the protocol demands aggressive antibiotic therapy.
And standard monotherapy often fails against biofilms, right?
It does. Guidelines recommend a double antibiotic therapy, typically a macrolide, combined with equinolone, taken for an extended period to ensure deep tissue penetration and eradication of any residual bacteria.
Okay, so that systematically dismantles the biofilm. What if the doctor is confident it is a cold nodule, a non-infectious granuloma where the immune system has built that fibrous capsule and infection has been definitively ruled out?
Then intralesional steroids become the appropriate tool to calm the immune response and shrink the fibrous capsule. However, specialists often compound the steroid with a drug called 5-fluorouracil, or 5-FU.
I saw 5-FU mentioned in the literature, and it totally caught my attention because it's widely known in the oncology world as a chemotherapy agent. Why are they injecting a chemotherapy drug into a lip lump?
It comes down to stopping cellular division. 5-FU is a master of molecular disguise. It closely mimics a fundamental building block of DNA called uracil.
Okay.
When the overactive immune cells and fibroblasts in the granuloma try to multiply and build more scar tissue, they mistakenly incorporate the 5-FU into their new DNA strands.
Oh, wow.
This sabotages the replication process, basically causing the capsule-building cells to self-destruct.
That is brilliant. It stops the factory building the biological wall. Plus, 5-FU also carries potent antimicrobial properties. So even if there happens to be a tiny, undetectable cluster of bacteria hiding deep inside the matrix, the 5-FU provides a secondary safety net to knock it out while the steroid calms the inflammation.
Exactly. It covers both bases simultaneously.
But we have to address the worst-case scenarios. What happens when these minimally invasive options run out? Like dealing with severe pus-filled abscesses or complications stemming from those permanent fillers where hyaluronidase is completely useless.
The final option is surgical intervention. For a fluctuant abscess, that means a surgical incision and drainage to manually evacuate the infection.
Ouch.
And for severe granulomas caused by permanent filler, it requires complete surgical excision. The surgeon has to literally cut the material out of the face or the labia entirely. The resulting permanent scarring and tissue loss completely defeat the original purpose of seeking cosmetic enhancement.
It is a remarkable journey, from a quick, seemingly simple lunchtime procedure to the potential reality of surgical excision. To bring this all together and answer the mission question we started with, can labial fillers cause lumps, nodules, or biofilms? The answer is an unequivocal yes.
A resounding yes. The causes span an incredibly wide spectrum.
On one side, we have simple mechanical, clumping the Ziploc bag of jelly being squished by hypermobile lip or labial muscles in the days following an injection.
And on the other extreme, we have deeply complex, delayed onset nodules erupting months or even years later, driven either by microscopic bacterial slime cities awakened by a trip to the dentist, or by rogue immune cells building a permanent fibrous fortress around a degrading gel fragment.
It is a lot of complex biology to process, but it demands a profound respect for the human body. We are not just injecting a static piece of plastic into inert clay.
Not at all. The moment that gel crosses the skin barrier, it integrates into a highly dynamic, living ecosystem. It is constantly interacting with your immune system, your shifting microbiome, your enzymes, and even your oral health. The critical question isn't how a filler looks in the clinic mirror on day one, but how your biology will choose to perceive it a year from now.
And looking ahead, that living ecosystem concept suggests a pretty wild future for this industry. If our bodies are constantly fighting these sterile gels, I have to wonder if the next leap in cosmetic injectables won't be about making fillers more synthetic, but actually engineering symbiotic friendly bacteria into the filler itself, like a microscopic peacekeeping force designed to actively tell the immune system to stand down and prevent pathogenic biofilms from taking over.
That would entirely redefine the concept of a biological implant.
It totally changes how you look at the whole field. It is not just about art and symmetry, it is hardcore immunology. Thank you for joining us on this deep dive. Stay curious, keep questioning the world around you, and always demand the why behind the what. Because as we learned today, sometimes what looks like a simple lump on an X-ray is actually a complex microscopic city hiding right beneath the surface.